Hello, this is Eric Ruderman coming to you for Room Now from the EULAR meeting in Barcelona. I wanted to talk about a semi-new drug, a drug called Deucravacitinib, a TYK2 inhibitor that's been approved for about a year now for treatment of psoriasis. And we've seen phase 2 data in psoriatic arthritis and assumed that eventually this is a drug that would become available. And at this meeting, two abstracts are presented with the two large phase 3 clinical trials of about 700 patients in each one, looking at deucravacitinib versus placebo to treat psoriatic arthritis. The upside of this drug is that it is an oral agent. It's given once a day. It's very specific for TYK2 as opposed to other members of the JAK family, which seems to reduce the risk of toxicity. Certainly, it seems to reduce the risk of some of the laboratory abnormalities that can be seen with other JAK inhibitors. And so far, uh, it has not been associated with some of the other issues, the cardiovascular issues and so forth, that have been associated potentially with other JAK inhibitors. They presented two large phase 3 trials at this meeting, both run in parallel and largely similar protocols. One compared deucravacitinib to placebo, and they included a safety reference arm of apremilast, not for efficacy, but just to look at some of the safety. Deucravacitinib was effective. It was statistically better than placebo, though the placebo response, interestingly, was quite high in that trial. It was more effective, at least nominally, than apremilast, though it wasn't powered to really test that statistically. And it did have actually fewer side effects. It did not have the GI side effects that are often seen with apremilast, the nausea and the diarrhea. The second trial looked at deucravacitinib versus placebo and selected for patients who were at higher risk for joint damage. These are patients who had at least one erosion upon entry into the trial, and were able to look at X-ray data in the trial. The pre-specified X-ray analysis did not meet its endpoint, but they presented some secondary analyses that have looked at that and suggested that, looked at another way, this may in fact halt or at least slow radiographic progression. What I don't know is where this drug is going to fit in. It appears to be effective. We really have no comparative data, including no really statistically valid comparative data against apremilast. It does seem to be effective. Is it more effective than apremilast? Probably. Is it as effective as some of the other biologics we're using? Don't know. Probably not, but we don't know. And I think it'll be really interesting when this gets to the clinic, which it will at some point, probably within the next year, based on these trials for psoriatic arthritis. It'll be interesting to see where people want to fit this in. It's intriguing to think about a once daily oral medication with very few side effects, um, and sort of stack that up against some of our other options, other oral drugs that may have more side effects or require more monitoring, like methotrexate, or against injectable drugs. I think that as people begin to use it, where it fits in will become more clear as they try to understand, which patients respond, which patients seem to want an oral agent. So it's an area to stay tuned in, but I think it was really intriguing at this meeting to see the phase 3 data, to see that this is a drug that's going to work. And it's definitely a drug that I think will become part of our toolkit. Where in the toolkit it fits has yet to be seen. And with that, this is Eric Ruderman again, coming to you for Room Now from Barcelona, the EULAR meeting.